saw of SEOW members was Bill, and of course Greg representing. I haven't seen Robert or Jeff join.
Robert and Jeff are both on.
Oh, good. Okay, so we're set. I see
them.
There you are. Yeah, I see Jeff. Hi, Jeff.
Good morning.
Yeah. Good morning. Okay, so I am going to call to order the June 6th, 2023 SEOW meeting of the Oregon Educators Benefit Board, and we are attending remotely and virtually. So welcome all. And as I say, this is one of those meetings where we're going to be looking at both PEB and OEB with the idea of having similar a work plan that will touch both of the entities, and we'll be starting with the dental clinical utilization targets. So before we do that, we do have an April meeting synopsis to review and approve. Any review or any approve?
Move to approve.
Second.
Thank you. All in favor, say aye.
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 Thank you. So we're on to our first topic, where we're going to be talking about the dental quality metrics. And if you remember from our April meeting, we asked KP and Willamette Dental Group to come together and give us a presentation on what they think their goal should be for OEB, the 2023-24 plan year, and we'll actually talk a little bit about the whole idea of measurement year, and then we'll have Delta Dental with their presentation. So it starts with Dr. Pilstrom and Dr. Chambers from KP and Willamette Dental Group, respectively. Gentlemen, how do you want to do this? Have you worked out a plan?
Oh yeah, we've worked out a plan. Can you hear me okay?
I can.
Great. Hi, Mark.
Hey, good morning, everyone.
Good morning. So I'll just start out. I think you know me and Mark well. We've met with the brokers, and we met together several times with Kaiser and Willamette to make sure that we're getting our data together, and making sure that we're kind of comparing apples to apples when we look at this. Just wanted to do a recap really quick. In dentistry, there's no national metrics that are universally used for care delivery systems or insurers, unlike medical, where HEDIS is really commonly used as a quality measurement. It's a very different culture and very different atmosphere when you look at performance measures in oral health and dentistry. I think the closest we've come in Oregon through the leadership of the Oregon Health Authority is some of the CCO metrics that have been used for their Medicaid populations. And we've used some of those, and you've used some of those by adopting and looking at the measures that we're going to be looking at in the next slide here. So I think that makes a lot of sense to do that. Having talked with Dr. Chambers and his team and our team, it's so early in the process. I think it's important to continue to monitor these moving forward. And there may be some tweaks and recommendations that we can make around monitoring and measurement in the future. But I think it's a good start. And then lastly, I just wanted to remind everyone that we've got very different care delivery systems. Kaiser and Willamette are both care and coverage, and we're very much focused on population health, incorporating evidence-based dentistry in the actual care delivery model, which shows up in things like risk assessment and how risk assessment affects the actions and behaviors of the care delivery team, and things like recall for patients and those types of things. Mark, any additions to that?
Yeah, and Dr. Pilstrom and we talked a lot about these evidence-based metrics, and Kaiser and Willamette are very passionate about these metrics really driving appropriate care to our patients. And when we talk about appropriate care, we're talking, are we getting the right preventative treatment to the right patient at the right time? And, focusing on those patients that need the help the most. And I think that's the greatest thing that, these metrics can help kind of steer the organizations to continuing to do that.
Great. Next slide, if we're all ready. So Dr. Chambers and I and our teams have put together these numbers. I'll go over my data. That's the first column there, Kaiser Permanente Dental. You can see the OEB percentage and the PEB percentage for the year 2023 to 2020, well, the 12-month of 2023 to 2024. So we've broken out the first two rows these are adults that are at moderate risk for tooth decay, and then at high risk for tooth decay. And you can see our percentages there. OEB in general, at least for our data, tends to outperform slightly with the adults for preventative services. We see a higher rate of preventative services for moderate and high risk patients compared to PEB. For children, about the same, right around that 50%. And then for oral evaluations for adults with diabetes, we're at 38%. And I'll just note that this last one was the one area where probably it's the hardest for the carriers to align around, because with Kaiser, we're using data in the electronic medical record that's listed in the problem list. So these are typically diagnosed by a doctor, a physician, or another care provider. And I'll let Willamette and Delta speak to how they do it, but that I think shows up with, it's a little bit harder to equate this across the different plans, I think. The other thing I'll say is that the Oregon Health Authority, through the CCOs and Willamette and Kaiser participate in those, and our CCOs, they measured children in the oral evaluation for adults with diabetes. They don't measure preventative services for adults. So that's a difference. It's a very new way of looking at it for us. But it was interesting to see this. One thing I'll leave you with, and I'll let Dr. Chambers talk about his data, is that we see a difference. It's more pronounced on our side between moderate risk and high risk patients who receive a cleaning in a year among adults. And I don't have the explanation other than kind of knowing that the behaviors among low risk, moderate risk, and high risk patients are a little bit different. And it could be driving their, willingness to come in for recalls, perhaps, or something's driving that's different, and I'm not quite sure what it is yet. Mark, do you want to go over your data?
Yeah, and let me kind of add on to what Dr. Filstrom was talking about with the difference between our moderate and high risk patient population, because we see it as well, that there is a reason that often those patients that are high risk, and a lot of it sometimes is compliance, it's home care, it's their willingness to follow through with recommendations. And having talked through it with Dr. Filstrom, both organizations, or both Kaiser and Willamette, are reaching out to those high-risk patients and trying to increase utilization of those preventative services, and we'll continue to do that. As you look at these numbers, there's a lot we can take from these numbers. First of all, if you look at them, I believe both organizations, Kaiser and Willamette, if you look at those high-risk and moderate-risk adults, we have great outreach to those people. And to say that we're getting in anywhere from 60 to 70% of our moderate and high-risk patients on an annual basis is a good start. When we look at children, 1 to 18, you'll notice that the numbers for children are a little lower than our adult preventative service utilization. And the reason being is that with the children, we're looking at all children regardless of risk. And whereas adults, these numbers are showing just our moderate and high risk. And just as with our adults, we target outreach to our moderate, high, and extreme risk children as well to get them in more often. So if we were to take out our low risk children, we'd see our number or the numbers increase significantly for utilization for children as well. In fact, they'd be comparable to that of what we're seeing with our adult populations. Dr. Filstrom talked about the challenges of diabetes and that metric, and how that's calculated. How we're calculating that is it's self-reported by the patients as they come in for dental treatment. And regardless of how we calculate that, it is interesting to see that our numbers are quite a bit higher than the CCO baseline percentage that has been set by the state. It's a lot to take in with these numbers, though. I mean, there's a lot to these numbers.
And I just wanted to help just level set to make sure we do understand them. So the two where in the middle of it says Kaiser Permanente and then 2022 measurement year, OEB, and then for PEB, and then Willamette Dental Group 2022 measurement year, OEB, and then PEB. Those are your proposed targets for that we'll look back at during next year's contract. Correct?
So actually, currently, Tom, that's actually our current numbers that we are getting.
Okay. So
yeah, the purple column, the baseline, is our proposal for monitoring.
Oh,
for
okay.
this contract year. And then next year, I think, is when we should relook at this and for contract year 2024, 2025, and kind of go, okay, this is where we want to go from there.
Okay. So this is so your experience, this was the part that I was confused about because I didn't understand what baseline SEOW percentage meant.
Okay.
If your target is essentially at or below your current experience. So in terms of looking at, and that being when we set targets, we essentially want to have stretch, show improvement. What we're saying is your targets are below what you're doing now, which is a little odd. It doesn't matter in that there are no fees at risk, but it was an odd. That's kind of an odd way of looking at targets. At least that was my thought. But again, it's the most important thing is that we are establishing what we're going to pay attention to. We're talking about having our plans look at what they need to do to improve, and that when we have the conversation around what those targets are going to be, that where actually fees are at risk, that's when, don't be surprised if that future SEOW group says, well, we're not going to accept having targets that are less than your current outcome.
Well, and that's a good point, because we, again, like I said at the top, Tom and others, doing this in dentistry is brand new. Nobody does this. And the organizations, I know my organization, it takes a while to move the organization to see improvement. And there's a delta here between Kaiser and Willamette.
I saw that also.
The question is are we going to have 3 different targets?
Yeah.
And then when you see the delta data, I think you're going to see different performance there. We're going to have a different, is everyone going to try to improve? It just really depends on what the group wants. And is it a target for improvement? Is it maintaining? Is it minimum threshold? It just all depends on the strategy that you guys want to adapt. And we're going to talk in the next slides around what we're doing to drive some of this utilization. But again, getting back to the care delivery models, In our program, in Willamette's program, we don't recommend preventative services to the degree that you're going to find in the community. So there are big differences when you start looking at these numbers, especially in adults.
Yeah.
With kids, I think everyone can agree that we want them to come in more frequently, almost regardless of risk. But that's going to be a challenge for SEOW and the carriers to get, you know, like the CCOs, they set one target for all the carriers.
Sure.
So.
Okay, so I now understand this target. And Rose, this would be the one slide that I would like to have present for the SEOW presentation
Okay,
at the full board. Thank you.
okay.
Okay, so the way that we had, you'll look in the agenda, there was going to be the KP Willamette Dental Group presentation, and then there was going to be the Delta Dental, and then we were going to have SEOW questions. I think it makes most sense for us to talk about the Willamette Dental Kaiser Permanente part first, and then have questions. And I'm going to acknowledge that you guys, that there's more that you're going to be talking about. But I do want to make sure that SEOW members, and that includes you, Greg, if you have questions about this slide, let's raise them now. Any questions about the slide that we're looking at now? Okay. If not, we'll then go ahead and continue. So you two are back on.
I think Dr. Chambers is up. Next slide, please.
Perfect. So just to kind of reference a little bit of what we're doing as an organization to, try to take care of, our patients. And there is considerable outreach, and these metrics that we share with you here are actually even a little watered down than from what we're doing with our providers in terms of, making sure the appropriate preventative care is being delivered. With that, I can tell you that, Tom, you talk about kind of stretching ourselves and making that next step, and that's obviously the goal that we're doing. But to let you know that we are, we've been pushing providers for years, and we've been doing risk assessments for about 12 years on every single patient. About 99.8% of our patients walking out the door after a cleaning have been risk assessed. They have a personal dental care plan and preventative products and recalls targeted off of evidence-based dentistry that will help get the patients healthier. So we're obviously going to keep stretching, but I just want everyone to know that we're making considerable efforts already, and will continue to make them. Probably one of the biggest challenges we face as an organization and dentistry as a whole right now is staffing, and we've talked a lot about this over the years, especially since COVID. We've increased pay, we've increased holiday days for employees. We have looked at flexible schedules that would allow employees that maybe have other obligations at home. Maybe a hygienist can work 20 hours a week, but they can't work 40 hours, and we're trying to be flexible with those hours so that we can accommodate increased patient utilization. Recruitment of providers. This last week, we just hired another provider for Eugene that has been a kind of a hotbed of staffing challenges. And we have another dentist from the state of Washington that is going to be transferring down, has applied for an Oregon dental license, and will be working in the Eugene area. We continue to waive copays for patients that to help encourage them to come in for the first time, encourage them to get the services they need. And we're actually on track for both OEB and PEB to surpass the number of copayment write-offs that we did last year in this coming year, which will be great. We've talked about our electronic health record and how we, about 2 years ago, we built in some prompts into the electronic health record that pops up and encourages our providers to provide preventative care. That's sealants, fluoride varnishes, appropriate cleaning recalls, appropriate x-ray intervals, making sure patients are getting appropriate x-rays, but not too many x-rays. We don't want to be exposing our patients to excess radiation. With that, those quality metrics that we have built into the electronic health record, that's one of the way our providers get compensated, right? Are they providing appropriate, good preventative care to patients? We also continue to send out recall reminders. We kind of revamped our recall reminder system last year to send out more prompts to people to make sure that they are showing up for their appointments. That was one of the challenges coming out of COVID, is that we did have a lot of no-shows from patients, and we've been able to increase patient compliance on showing up for patients through those recall reminders. The other thing that I think has been very beneficial is that with the relaxing of the emergency COVID protocols, and going back last year, if a provider had a cold or sniffles or anything that could be deemed a COVID symptom, they were restricted from coming into the office. And some of those restrictions have been lifted. We have providers that are now able to come in. Obviously, they need to be healthy, right? If they're very sick, but they're not going to be coming in. But if they have seasonal allergies or a cough or something that's not COVID related, they're able to come into the clinic and still work. We also have we've talked about the OEB and PEB outreach that we've done to patients, and we've completed that for OEB, and we're continuing to outreach to the PEB patients for those that have never been into the clinic. Kristen, it looks like you may have a question.
Hi, Dr. Chambers. Yeah, I do have a question. So it's all encouraging, that Willamette Dental is making progress on general access. But just thinking about a couple things that came up on the previous slide and then what we're seeing on this slide as well. And I don't know, Rose, if you can go back one slide for us. I think maybe we can tie a couple things together. So really, and it maybe was Dr. Philstrom who led the meeting off by saying this: we want performance guarantees and targets that drive towards outcomes. And, really what sticks out to me here, and Dr. Chambers, you talked about this as well, it's really the high risk patients that we want in the office more. And it's actually the high risk patients that are going into the office less, maybe because they're high risk because they don't have good dental habits, and they're sort of driving that. So to me, it seems like a natural place to focus would be, we need to be increasing our engagement with our high risk members. And that would be an area where we would want meaningful improvement in the target over time. I think the target would be increasing there. But also on the next slide, in all of those things that Willamette Dental is doing to increase access and engage with members, there's nothing here really that talks about addressing dental behavior of those high-risk members and how we specifically would increase their office visit service rate. Just wondering if you could talk a little bit about that, and then maybe offer a suggestion for if we were to increase, maybe it's 2% per year additional over the prior year, have an increasing target for the percentage of high-risk adults getting office visits, and then some sort of action Willamette Dental is taking to drive that engagement. Do you have any thoughts about what that would look like?
Yeah, so that's great. And I mean, I agree. I think we all agree that targeting preventive services to those that need it the most, it's going to be the most beneficial, right? And so let me tell you a little bit what we're doing currently for that. Our care advocates, who are our front desk employees, we have recall lists, and they're reaching out and calling those patients. They're receiving text messages. Those high-risk individuals are set for a recall to come in every 3 months or 6 months, depending on the severity of their disease. And that's across the board for all high-risk patients. I mean, they are set for either 3 months or 6 months. And we spend considerable amount of time in those appointments trying to educate those patients on the importance of them returning for their recalls. And as we get a patient that becomes more involved with the clinic, they start to know the doctors and the hygienists. We do start to see better compliance as they start to feel more comfortable in the offices. So we're always working on trying to build that personal connection with the patients to hopefully make them feel more comfortable. Sometimes those high-risk patients, it's a dental phobia. They're just nervous about coming in. I spent a summer doing research when I was in dental school, and I spent it in the Hispanic population in Eastern Washington, and we're validating a dental fear measure. And it was interesting to see that the outcome of that study was that the number one fear was actually not needles, or it wasn't getting drilled on, although those were fears. The number one fear that patient population had was fear of being told that they were doing something wrong, or fear that they were being told that their teeth were in bad shape. And that takes time, obviously, to build that relationship with that patient and hopefully overcome those obstacles. But we will continue to work on those things.
Yeah, that's very interesting, actually. So in terms of the performance metric target for that specific population, and I do think it makes sense to have the Willamette Dental and Kaiser targets be different. It doesn't make sense at all to have a Willamette Dental target that's like 20 points, below where you're currently at today. So if we were going to focus on increasing the bar on that one a little bit over time, maybe we could ask you guys to think about that and come back to us via email in a week or so with what that would look like. And we'd ask the same of Kaiser.
Yeah, and I think that this is the biggest challenge for your two organizations. So of trying to, and it almost is starts with a review of the literature. What's the best practice, nationally or even internationally for addressing the issues of high risk, and trying to look to see if there's an evidence basis for doing that. But definitely finding targets and having setting up improvement is critical, just as Kirsten ended up saying.
So the one thing I'll say is that as we raise that bar, right, maybe moving up 1% takes a certain amount of effort, but as we start to, there's only so much you can squeeze out of patients, right? So as we start talking about jumping that bar up, and I can tell you, we're already squeezing pretty hard trying to get these patients in, and I'm not saying we can't improve, but in terms of how much we can improve, there is the patient component of it, of compliance and their willingness to come in.
Yeah, there's no question about that. And as Dan talked about early on, this is one where we're going to be learning as we go along. But I appreciate Kirsten's comment around incremental improvement. I mean, that's just one of the things that is kind of key in quality metrics. That's that becomes the push to help organizations focus more. We're running low on time, and Kirsten, did you get your? I don't want to be blocking any additional thoughts you have, but
no,
again,
thanks, Tom. That was full discussion. That's great.
Okay, so Dan,
sounds
like
we got one more slide. If I can introduce Santo Graziano, our Director of Operations. But before I do, because he's right here, I just want to answer your question, Kristen, too, from my standpoint. One of the things, and I think it's the reason why the Oregon Health Authority doesn't have an adult preventative services in their CCO metric, is that adult services are more complicated than kids. We provided a risk assessment that looks at tooth decay, but adults suffer from periodontal disease as well, and it's not included in this. And they get different cleanings. They're called periodontal maintenance cleanings. And we have different risk assessments for periodontal disease. Whereas kids, they all get the same thing, ProFeed, preventative services. And a preventative service is more than just a cleaning, but it's how most of the care deliveries deliver the type of service. It's a preventative service type appointment. So just keep that in mind. It's a little bit more complex with adult dentistry than children dentistry. And I'll just echo the same things that Dr. Chambers said. We do give there's specific sort of protocols that higher risk patients fall into in terms of their recall status, frequency of x-rays and things like that. And I think that what this is doing is it's pushing the organizations, and as we presented this, it's making me think about, okay, what do we need to do to drive specifically the high risk patients in a different way that we haven't done? So that's what this is all about. So you got the wheels churning, which I think is the goal this year, and we'll revisit it next year. I want to introduce Santo before we're totally out of time.
Yeah. Santo,
Right.
you've got 4 minutes, Santo.
4 minutes. All right. Thank you, Dr. Siltabo. And so we're doing some of the same things around recruiting, really trying to hire our hygienists up to where we were pre-pandemic levels, and we're well on track for that and getting there. Dental assistants, providing some tuition, scholarship opportunities and things to really try to create a labor pool there. We're doing outreach to different community groups to get people into health careers that normally would have had some systemic barriers preventing them for entry into school and things. So a lot of work being done there to redevelop a workforce. So around outreach, some of our pieces are really technology focused. So text and email outreach. We have scheduling tickets being sent when folks are due and active on kp.org and appointments available, and they can select from those and book into it. We created online appointing for emergency dental visits as well, and some things with our wait lists around FastPass, so that there's that ability for those quick, easy books all through the app. Exploring virtual dentistry and advice and some avenues that we've added there. And then really around that member outreach, so how we're targeting different populations. And one thing, Kaiser Permanente, what makes us unique, we've talked about medical dental integration. A piece of that is in medical, that our physicians, nurse practitioners, especially in pediatrics, being able to apply fluoride varnish. And they see that as a care gap for the patient that they're seeing in the exam room. And, as we talk about how to reach some of these populations that either haven't been into the dentist or utilize it, we're testing different avenues. We've used a text appointment system for one group to test the responses there. In medical, we have a centralized and methodical outreach methodology that we're going to attempt to try and emulate some of those things within dental, and testing it in different environments to see how our members respond to those and how we can fill things up. But overall, we're doing pretty well there. Where for emergency visits, sure, 99% are being seen within 2 days or less. The remainder of our members were running, about 55% being seen within 10 days of when they're due, is how we're factoring that in. But definitely some opportunities that we're exploring on outreach, and are excited to see what we can do through this year.
Okay, any questions from the SEOW committee members? Alrighty.
None from me.
Yes, Jeff. Okay, thank you, Jeff. Okay, thank you very much. I'm really pleased that we're at this point where we're and I don't think I'm not at a point where I think we have to have a big debate over what the targets are. I'm fine with the ones that you have set, acknowledging the fact that this is the year that we're basically setting what they're going to be. And again, the hard conversations will be, after we have a little bit of experience. But I think what Kirsten has said and what I've said, pretty clear that we need to basically take baselines and come up with improvement over those over time. but we've got a year now, and we'll have the conversation again sometime early to mid next year. Okay, we're on now to Delta Dental and Dr. Baracello. Terry.
Yeah, so actually, Tom, you're getting me today. Dr. Baracello was really hoping to be here today, but unfortunately, she had something come up and she's not able to be here.
I'm sorry. Okay, well,
yes.
you're a good substitute.
I'm a substitute, but definitely cannot come close to filling the shoes of Dr. Baracello, but I'm going to try my hardest.
I wouldn't want you to try to do a dental procedure on me.
Yeah, that wouldn't be a good idea. Rose, can we go? Oh, and I guess I'll introduce myself really quick. I think I know pretty much everybody here, but my name is Erica Hedberg, and I am the Director of Government Programs for MODA. And next slide, Rose. And so first, I'm gonna present just what our proposed dental performance guarantee targets are, and then I'm going to show some historical data. And then per the conversation at the board meeting, I've broken out that data by race and ethnicity, and then also by region. Next slide, Rose. All right, so there are currently 3 measures in our contract, in our dental contract that we've been reporting, and 2 of those are listed here, and then the 3rd one is a new one. So we've been reporting annual preventive services for adults and for children, and then as we've discussed, adding oral health evaluation for diabetes to our reporting for the contract. And our proposed targets for those are 60% for the annual preventive services for adults, 70% for children, and then 60% for diabetes. And then I'm going to now go into just showing what our data has been like for the last few years to pretty much show how we came up with those targets. Because as it was mentioned in the last presentation, it's different than medical, as everybody knows, that there aren't really any set benchmarks that we can look to for these targets.
Erica, maybe you're going to get there, but we had agreed when we talked about this initially in the April meeting, I think, that MODA or Delta Dental, just by virtue of where you were already, was going to focus on setting targets by race and ethnicity to make sure that all of the different OEB members were at the target and not just looking at an average. Did you guys have a chance to do that?
Yes, and I have that here in the presentation in the future slides.
Oh, perfect. Thank you.
And what you'll see when we get there is that it's our proposal to report them, but not to put fees at risk, broken out by race and ethnicity. And I'll show you why when we get to those slides.
Right.
So next slide, Rose. So we have both OEB and PEB data in here, but I've put the PEB data in the appendix. And the reason for that is because just looking at one group is a lot of numbers. Putting 2 groups on the slides together would be a bit overwhelming. But spoiler alert, PEB is pretty consistent with OEB in terms of the percentages. So what I've done here is I've shown the 3 proposed measures and then how we've performed for the last 3 plan years. And then I've also included our book of business peer. And for book of business peer, that includes public entities within Oregon. So that's who we're comparing to. We know that public entities tend to perform higher than a normal commercial plan. And as you can see here, OEB and PEB are performing higher than our public employee peer as well. And so for preventive adults, you'll see that we've been right around 63 to 64% for the last few years. For preventive services for children, we've been right around 75 to 77% for the last few years. And then diabetes oral evaluation, we're in the low 60s. And one thing I want to point out for the diabetes measure is that we can only compare to groups that have both medical and dental with us. So that book of business peer is a lot smaller than the peer for the other 2 measures. But what you'll see here, just as a theme, is that, again, OEB and PEB are performing higher than the standard groups on these measures. And so the proposed targets that we set are higher than our book of business, but you'll see that OEB is exceeding the targets that we've set for those measures because OEB is a very high performing group when it comes to these measures. All right, next slide.
Once again, if the proposed targets are significantly below your 3 years of experience, which again, the fact that there are no fees at risk, I don't particularly care. But when fees are at risk, I don't think SEOW is going to would have accepted. If fees are at risk, I don't think SEOW or the boards would accept what you proposed.
Yeah, and I think what we're trying to show with the data is that OWEB is a high performing plan. I think it would be difficult to continue to increase that percentage on a population that's already very high performing, but definitely understand your point on that, Tom. And Kirsten, per your comment, we did break out this data by race and ethnicity. The first one's broken out by race, and I included the numerator and denominator here to show how many people we have in each of those categories. So you'll see that the non-white group is performing at 54.2% for the last plan year. The white group is performing at 64.3%. And then we have an unknown category that's performing at 61.1%. And what you'll see here is that the unknown category for all of these measures is the same size or larger than the non-white category. And just to say that as we're trying to continue to improve on the race and ethnicity data that we have collected, we still have a pretty large percentage of our population that we don't have the data on yet.
Yeah, this is really helpful, though. I mean, a couple things immediately.
I'm going to let me interrupt for a minute. I just my network just went down for the last about minute and a half, so I missed what all of you were saying.
Oh, okay. I'll repeat that really quick, Tom.
It doesn't matter. It doesn't matter. I just wanted
Okay.
you to know why I didn't.
Great.
Oh, we might have lost Tom again.
Kirsten, did you have a comment?
I did, but let's give Tom a minute and see if his connection comes back.
Okay.
Okay, well, I
Can you
think
give
while
me
we.
the
Oh,
telephone number to
perfect.
phone to?
Tom, I think we can hear you now that you're on your phone. Oh, but now you're muted.
Hey, everybody. I'm on the phone with Tom. I'm going to give him the phone. He's going to call in, but so I just wanted to let you know.
Great. Thanks, Glenn.
My apologies.
Oh, no problem, Tom. No problem.
Actually, it is a problem, but
No, I mean, yeah, the phone number to
happens.
call in is 1-971-277-2343, and the phone conference ID is 498-190-242, followed by the pound sign.
thank you.
Tom is calling in. Kirsten, why don't you go ahead with your question?
Okay, sure, Glenn. Erica, this is really exciting to be able to see the data this way. This is exactly why I think we were asking for this. And a couple things come to mind. I think this came up in the earlier conversation too, and just we'll reiterate it now. Looking for the places where we can make incremental improvement. In the first conversation, it was around high-risk adults because we had that reporting available. Here, it's very clear, we have the opportunity to strive for improvement in the non-white and unknown populations as well. Bare minimum, we can start with bringing those up to where the white population is, and then we can have another discussion about does the whole population need to, go up anymore? What is an optimal target?
Yeah. And Kirsten, you'll see on the preventive services children, the unknown is actually higher than the other two categories.
Yeah, I noticed that too. And that actually made me think, as much as we're talking about, well, maybe 63.3% is a ceiling on preventive care for adults. Well, it is possible to get higher, right? Because we're seeing that with the children below.
Yeah. Yes, it could be a possibility, Kirsten. And then I'm going to go now to can you go to the next slide, Rose, please? And this is the diabetes one broken out. And here you'll just notice that the denominators are just small all around on this one. Though funny enough, they're the most closely aligned of the three measures.
Can you just, guys, just hold on. Tom, were you
I'm
able
here.
to? Oh, okay. I just wanted to make sure.
Yeah, I'm good. I'm actually I'm watching it on the computer, and as that goes in and out, I'm just going to use my phone for the communication part.
Okay, go ahead.
Thank you,
Erica.
Thanks. And one thing to call out, this slide should say performance by race, not ethnicity. And so we broke out, if you go to the next slide, that was everything broken out by race. Now we'll break everything out by ethnicity. So we have Hispanic, non-Hispanic, and unknown. And for the first measure, you'll see that Hispanic performed higher on the oral evaluation for diabetes. But in the other measures, they are lower than the other. Sorry, I need to relook at this. We have the three measures broken out. I changed the chart type here. So preventive services adults, you'll see that the non-Hispanic performed the highest at 64.3%, and then Hispanic is performing the lowest, and then unknown. Again, I didn't include the denominators here, but very similar denominators to the race and ethnicity or the race breakout that we had. For preventive services children, same story. The non-Hispanics have the highest percentage, and the unknown and Hispanics are lower. And then, although the Hispanics, all groups are above the 70% here for children. And then the oral health evaluation, the Hispanics are performing higher, but again, those numbers are so much, the denominator is pretty low on that measure. So I don't know that I would make a lot of assumptions about the oral health evaluation for diabetes right there. And again, on these ones, we are proposing to continue to report these ones, but just due to some of the data, we would recommend not putting fees at risk on them. Next slide, Rose. And so we also broke out the data by region as well. So starting again with the preventive services adults, you'll see that urban, I think this is what we did expect to see, is performing the highest at 66%. However, all groups are above that 60% except for out of state. And the one thing I will say about the out of state is the majority of those members are out of area dependents who are between the ages of 18 and 26. And we do know that members in that age group tend to be more of a transition and do have lower preventive utilization than the other age groups do. And so you have a larger percentage of those members in that age group, which is what I assume is driving down that rate for the out-of-state members. And then when you're looking at the preventive services for children, the urban again is the highest has the highest utilization, but all groups are above 70%. And then the oral health for diabetes, oral evaluation for diabetes, same story. The urban has a higher percentage, and Central Eastern Oregon is significantly lower for the diabetes. But again, that denominator would be very small.
Obviously, the Central and Eastern Oregon data jumps out as something that needs attention. This is bigger than Delta Dental. I mean, this is not. I don't think this is a health plan performance issue. My guess is both member attitudes towards dentistry and availability of dental services. And Greg, do you have a comment?
Just a question on the data. In what you're talking about with the Eastern and Central Oregon, I know a lot of our individuals live on the border. So in your out of state, like myself, for instance, I live in Hermiston, Oregon, but I go to Washington for my dental. So is that captured as in what I'm wondering is you know what I'm asking? Am I captured in one, other, or both?
Yeah, I anticipated this question, and you would be captured in Central Eastern Oregon. Okay. Yeah, and what we do when we pull these is those border counties, you know, especially when you're looking at Idaho. So any utilization into Boise would have been brought into the Central Eastern Oregon. If you're up in the northern part of the state, then we would have brought you down into Central Eastern Oregon as well. And that, I believe, Rose, if you go to the next slide. Yeah, and then I just have the PEB data following. And again, it's very similar to the OWEB data, but all of the same breakouts.
Do we have any questions or comments from SEOW members?
I have one. Going back on this slide, Erica. Actually, as the previous slide, the percentage for the child preventative services in Central Eastern Oregon was significantly higher than the adult piece. So when we're talking about access, is it because there are just that many more adults than children that the gap is that big, or what do you think it is?
Yeah, and you know, that is where I wish Dr. Barrichello was here for today. And I will take that question back to Dr. Barrichello and we'll send that over and get a response to you.
Okay, thanks.
Yeah, we know that there's an urban-rural gap, and not all of Central Eastern Oregon is, I would call Bend area urban to a degree, but still there are, Greg, you know, Hermiston is rural. And, you know, in terms of concentration or lack thereof of medical and dental services. So as you say, you go to Washington, you know, you have a urban center 30 miles away in Richland and the Tri-Cities.
Yes.
Yeah. Okay. Any other comments or questions from SEOW members?
Erica, we're wondering about looking at, because a couple of things really stood out with both the race and ethnicity cut and also the geography cut. And we're curious if you could let us know, can you do both at the same time?
I'm sorry, repeat that question, Kirsten.
So could you report on the same statistics by race and ethnicity by geography as well? Maybe, you know, offline this week or next week.
Yeah, we can definitely do that, knowing that the denominator will be small.
Yeah, understood. It might not work for all the regions.
Yeah, but we can do that. And I just saw the comment that came in too, and absolutely, thanks for noting that.
Okay. The next question, or I guess we have to address the issue, and I'd like your thoughts on this, Kirsten. The three dental plans have given us recommendations for next year's targets. I have said I don't care because in a way it doesn't, there's nothing at risk. So in a way it's a free pass, but I've also said it's not going to be a free pass in the future. Are you, as our consultant representative, are you okay with just saying, going along with what I just said?
In terms of not putting fees at risk, I think,
No, no,
Tom,
not at.
oh.
We already agreed that fees weren't at risk. The issue was for sure they're not stretch goals.
I think if you don't mind, we'd like to take what the carriers proposed today in the meeting and add some nuance. I think, you know, we're at a point now where we've had these dental programs in place for a really long time. We've had medical stretch goals, like we know how to do this, and instead of kicking that can down the road again, I don't think that's necessary. Maybe we can just take the week and send something back to the carriers that proposes improvement in a few places.
Super. Any comment from SEOW members about that? What Kirsten just recommended? I'm fine with that recommendation.
I'm in agreement.
Yes.
Greg, Bill?
Oh, sorry, I was giving you the thumbs up, but I realized you're on the phone. Yep.
Yeah, sorry.
Yes.
There you are. And Greg?
No, I think that's absolutely perfect.
Okay. All right. So Kirsten, work with the plans and come back. We'll figure out how we're going to get that information out to the SEOW members.
Great.
Thank you. Any other, Erica, is that the end of your presentation?
It is, yes. Thanks, Tom.
Okay, thank you. And any other discussion from SEOW about the dental quality metrics? Otherwise, we move on to our last topic, which is we're going to be going through the SEOW work plan. What's exciting about it is we actually we're going to be going to summer school, and Kirsten is going to walk us through this.
I love the way you put that, Tom. It will feel like summer school. I just wanted to set this discussion with a quick recap of the OWEB board goals. They're probably, you guys have them all memorized by this point, but we always just have them in mind when we're setting our agendas for the board and for SEOW each month, and then also the trajectory for the whole year, knowing that these 4 goals, there were 5, but these 4 goals really drive when we do the work and what work we do. The first goal was our shift left idea of catching and treating disease earlier and really embracing new programs and leveraging new technologies to do that. We had the goal to focus on quality and efficiency, but notably without sacrificing the members' satisfaction or well-being, always keeping the member first. We have the goal always of keeping the overall medical, dental, vision, pharmacy program renewal within 3.4%. So we're keeping that program affordable and also meeting the legislative requirement. And then we had a goal of member education, and I took the liberty of expanding this a little bit just based on all of the discussions that we've together been having in SEOW over the last few months, which is really education is in a more broad sense. Certainly it's the members, because we want them to understand their benefits, be able to use their benefits, take full advantage of what's available. But we also have this idea of educating all of the other individuals and entities that touch the OWEB program, and there are a lot. And then I folded in that 5th goal of legislators into that education idea. We had this fifth goal of somehow helping legislators have a better understanding of what legislation impacts OWEB and how, and PEB as well, of course. And so if we can fold in that idea of education, really we're reaching everybody. So we just have these goals in mind as we talk through the draft SEOW agenda, and then I know we're going to have some discussion about it as well over the next year and how those agenda items help us meet our goals. Next slide, please. You know, as we were really thinking about the SEOW agenda and reflecting on the last year, which has been an incredible first year with all of you, so thank you so much for that, and thinking about all of the lessons learned and what we want to take from past years and incorporate in the upcoming year, we kind of realized that SEOW is operating in 5 major areas of service it's performing for the board. And so these aren't new things. These are things that you and us collectively were already doing, but we're just maybe writing it down so we can see it in front of us and have it in mind as a structure for guiding how we set agendas going in the future. One of those is this strategic function, where SEOW helps the OWEB board achieve its goals by providing clinical oversight and guidance of carrier and vendor partners. And we saw this come up during the renewal. You know, there's really two kinds of renewals, right? There's the financial renewal, which is what are the benefits, the cost share, and the premium. But then there's also, how are we improving member health? And that's clinical, and we really rely on the SEOW's clinical expertise led by Dr. Siltebo to help guide the board's decision-making there. Another key area that SEOW provides service to for the board is in advancement, exploring leading edge physical behavioral health care and social benefits. Two recent examples of that, we talked about PRP therapy for MSK conditions, decided not to go forward with that with the SEOW recommendation. And then also the SEOW recommendation did promote the idea of a doula coverage. And as Tom mentioned, we're going to be collaborating this summer at summer school to get that benefit built. SEOW has the major function of assessing the ongoing value of OWEB's current programs to make sure that we are providing high quality, efficient, and member first care, because at the end of the day, we do have a fixed budget and we want to make sure we're doing the most for our members that we can with that. We'll see how some upcoming projects fit in with that goal. Accountability, many of the agenda items are going to fall under accountability, which is asking our carrier and vendor partners to come and talk about the programs that they sold us last year and the year before, and show us their results that they're getting. Are they delivering on the promises that they made to us during the renewal process? And then SEOW also identifies opportunities for the OWEB board to focus on in next year's renewal, maybe related to a benefit opportunity or an emerging medical or pharmacy condition that we need to get on top of. So we, as I said, really took the great work that SEOW was already doing and formalized it into this idea. So we could be asking ourselves, as we're building agendas throughout the upcoming year, are the agendas balanced in terms of focusing on all of these key areas, and are we driving to this ultimate goal of helping the OWEB board make renewal decisions for the upcoming plan year next year? Next slide, please. Great, so we have a lot going on this summer actually. In addition to the doula benefit coverage we're going to be working on for OWEB and PEB, we're really excited to have that joint venture going on. We're also going to be kicking off a joint work group, OWEB and PEB as well, to look at GLP-1 drug coverage. That's a class of anti-obesity medications. And we're going to be looking at an anti-obesity medication coverage policy with our carrier partners, Providence, Kaiser, and Moda, in anticipation of next fall, where we're going to do a deep dive with the OWEB board into OWEB's cost and utilization reports, again, looking for all of those opportunities. Where can we have the most impact for our effort and time and money? We're going to start working on the cost and utilization reports this summer. Also, we have a couple member benefit requests. So this is exploring opportunities for future benefits related to infertility and chiropractic visit limits. We're going to give the carriers advance notice, although you're getting it right now, that we're going to be asking for clinical program renewal ideas much earlier than we historically have. Last year and in prior years, we typically send out a renewal letter in December, but it just was so clear that given the level of sophistication and innovation and all of the ideas being talked about, we just need more time to fully vet them and get them in a place where they could be operationally practical for OWEB. So we're going to kick that off this summer and ask the carriers to start bringing us ideas as early as September. And then also kicking off this summer, we're going to start this cadence, and this is really based on feedback that we all got from you last year, which is these meetings are much more exciting and engaging when there's lots of discussion and it's not just a report out. So instead of having inviting our vendor partners or carrier partners or even Mercer to just report on data and then have the group sit and listen and maybe ask some questions, we're going to start requesting all of the reporting ahead of time, so that we can put together an agenda item that maybe covers highlights, has some questions, and a guided discussion for the SEOW board. And that will happen with the diabetes prevention programs. We'll talk about wellness report results. We'll look at MODA 360, Behavioral Health 360, PCP 360. And then along that SEOW service of assessing the value of current programs, we're going to dig into Weight Watchers and really understand the value it's providing OEBS members. So lots going on behind the scenes over the summer, and thanks to all of you who have agreed to share your precious time with us on those work groups over the summer. Rose, next slide. Great, so we have a couple slides now for September, not October, you'll see why, November and December, that highlight the tentative work plan at this time. And I'll just say tentative because maybe at the direction of the OEB board or other needs that come up, we may need to adjust. So this is just an early look at what we have going on, and we're driving towards this ultimate goal of having a well-packaged and formulated recommendation from SEOW and the SEOW committee to the OEB board in December for the upcoming renewal. So the OEB board will have all of the information it needs to start making some more targeted decisions about the direction to take the renewal. So that's what we're driving towards in December. In September, the meetings agenda items are largely about accountability and assessment. And then we've got some opportunity and advancement with the doula coverage work groups and the weight loss drug coverage work groups as well. We're going to kick off some work for the next month in September as well, thinking about clinical metrics. This is when we actually get some reporting on the actual clinical metrics compared to targets. And we'll come together as a group and have a discussion about, do we want these same metrics with these same targets in the future year? And we'll also start to receive from the carriers their proposal for clinical program ideas for OEB. Next slide. In October, the tentative plan at the moment is to reserve all day Tuesday, October 3rd for the board retreat. We wanted to have that earlier in the year so we could dedicate that day, among other things, to going through the cost and utilization reports together and really taking a deep dive into OEB's data and understanding what are the next biggest areas of opportunity, because remember, we've decided at last renewal to pick off cardiometabolic disorders first. So we have a lot of work underway around obesity and diabetes. And in these cost and utilization reports, we'll look together, where do we want to focus next in the next renewal? So no CL meeting that day. In November, go forward, yep. In November, we're going to share the results of the Weight Watchers value assessment. But again, with this idea of we'll look at the report results behind the scenes and put together an agenda that facilitates more discussion items around now what, and how can we better, if improvement is needed, how can we deliver a better product to members? We'll have a discussion from Mercer about the weight loss vendor landscape and how that has changed in the decade plus since Weight Watchers was first put in place, just so we have all the information available. And then depending on what comes out of the October board meeting, let's say the board decides that after we wrap up cardiometabolic disorders, let's turn our attention to cancer. And then the SEOW committee can take that direction from the board, and we'll do a deep dive into that clinical area of opportunity in November as well. We'll start working to consolidate all of the work we've been doing from really now, because we're kicking off these summer work groups soon. So all of the work from then until the end of November, we'll start to get that all wrapped up and make some decisions around what the SEOW committee wants to recommend out to the board and what we're going to save or kill. All right, and then in December, we have the member benefit requests, so we'll come back and make a final recommendation about those for chiropractic and infertility. And then we'll, as the SEOW committee, we'll discuss the carrier proposed clinical recommendations and then put together our own clinical recommendations and roll that up into one overall clinical renewal package, which would be shared with the board for their consideration. And then again, there's the little asterisk that the final work plan is likely to be different as actual needs change and things come up throughout the fall. Are there any questions or comments about the proposed drafted agenda?
My only comment is it's a lot of work to do, and yet we ended up having the conversations this year and realized that we hadn't done the homework ahead of time. So you only are able to address complex issues, clinical issues, if you need a work plan that allows for that, for all the exploration. We're also interested in hearing, besides from staff and SEOW members and Mercer, we're interested in comments from our health plan partners. So I welcome people joining in again from both MODA and Kaiser Permanente in terms of the conversation of the next 6 months of work that Kirsten has outlined. Not all at once.
Tom, I'm kind of a lame duck, so I'm not commenting.
Okay. I don't view you as lame, and I don't view you as a duck. So you can call yourself whatever you want.
And Tom, this is Erica.
Yeah.
Thanks for the opportunity. But we're aligned and ready to work in these groups over this summer as well.
Super. Bill, I saw you pop up.
Oh, I was just saying that I'm good. I think it's a lot of work as well, but it's all important.
And I'll just say I appreciate the forethought and the planning on this. I look forward to that.
Yeah. And Greg and I actually, right as the meeting just getting started, commented on how he has actually joined one of the work groups. We said that it will be an education, but also having board participants in this will be pretty interesting. Sapari, Keith, do you have any comment?
Hi, Dr. Siltabo. Thank you. No, we are in alignment. I think the only comment that I would have would be with respect to the timing for the clinical programs reporting out in September, maybe a little bit soon. However, I'm hoping it's more of a, if we have additional programs to add beyond September, that we could definitely bring that up.
My response to that is I don't think that if something amazing comes along after September 1, we'd be fools not to not to listen to that. The issue is just to make sure that if there are things that, let's say, are controversial and we know they're coming, that we have a chance to study it ahead of time. So it's so we don't get into a position of saying great idea, but we didn't have time to study it. So I think that what you just commented on, I can't imagine why we wouldn't follow that.
Perfect. Thank you.
Yeah, my only additional concern or comment relates to pharmaceuticals and our regional formulary and therapeutics committee, which each plan has. So anything that would subvert that process or compete with that process would be challenging to do, since that is an evidence-based process that's, for us at least, is really consistent across all of our commercial plans and really across all lines of business, except for rare exceptions. So that's just going to need further conversation whether or not talking about specific medications is even feasible. Yeah.
Keith, and we've had a bit of a conversation over the last couple of months as that whole issue, this specifically relates at this point to the weight loss medications, the GLP-1s. I think I got that right. the issue is nothing that we do affects the decision making that occurs between the medical provider and the member slash patient. And also the entities have pharmacy and therapeutic committees that then go on and give evidence-based recommendations. That the existence of both of those two factors need to be included in the workflow and the discussion for that particular work group. This needs to be included.
Appreciate that.
Okay. Any other? Again, I'm very pleased with how Mercer has outlined this, and the fact that it sounds like everyone is on board with this plan. Kirsten, do you then are you going to tell us more about the infrastructure for this?
For the summer work groups, Tom, or just in general?
Yeah, no, for the summer work groups.
Yeah, I'm happy to talk through that. And we're finalizing that, as you can imagine, because we're including OEB and PEB in that effort. And there are representatives now from 3 carriers, MODA, Kaiser, and Providence, as well as representatives from staff, OEB board, PEB board, and Mercer. It's been logistically complicated to get all of that arranged. What we're thinking at this time, though, really to maximize the input, the impact of our work this summer, and also really tread carefully on everybody's summertime, is to have one joint leadership team, and we'll meet monthly, hopefully for as short of a time as possible, no more than an hour. And the leadership team will make decisions and keep the work groups on track. And then to actually get the work done for the GLP-1 coverage exploration and the doula coverage build, we'll have work groups led by Mercer, but with all of those participants and representatives I mentioned, including staff from the carriers, to actually do the legwork on those benefits. We're thinking at this time of meeting bi-weekly for an hour, maybe having those meetings be back to back so that attendees who are in common to both, it's easier for scheduling. And then we understand people are going to be out for the summer, so we're thinking at this time we'll take really good notes and share those after every work group update. So if you miss due to traveling, it's understandable. You can just review the notes and jump right in when you get back. And then we're hoping to meet our first milestone in time to report out to the SEOW committee in September at our very first September meeting on the progress made on each of the work groups over the summer. And I'm really excited for these. You know, we're answering very different questions with those 2 benefits. We're impacting different groups of people with different medical conditions. With the doula coverage work group, we're really looking at questions around covering providers who aren't licensed, and what should the reimbursement rate be, and how many visits should be included pre and post delivery. How do we best design this program? And we're on the leading edge of commercial Oregon insurance in designing this doula program, which is, it's a goal of OEB and PEB. Also, it's exciting. And then with the GLP-1 coverage, there are more complex discussions. Dr. Bachman raised a point about carrier autonomy and maintaining their own coverage policies. We also are balancing a lot of member pressure and member awareness around these drugs, as in addition to an immense need for more treatment options in this space. So we have a real opportunity with our GLP-1 coverage policy and the broader cardiometabolic disorder work we're doing to impact, combined between OEB and PEB, if we're thinking 30% of the population now, like we're north of 50,000 members, which is, it's super exciting to think about being able to help that number of people out. So it'd be exciting work. Stay tuned for emails around maybe some meeting surveys to get like good times for people, but all that will be sorted out this week and next, and then we'll see you soon.
Okay. Okay, so any other, yes, Glenn.
I just wanted to one thing we wanted to raise here at the SEOW meeting was since Kristen's given a really good overview of the 3 work groups, Tom is currently on the leadership work group, but we wanted to see from the OEB SEOW members, we have Greg is going to be for PEB on the doula work group, and Sean Parkman will be on the representing PEB on the GLP-1 work group. We wanted to raise with the other SEO members whether they would, consider participating. We need 1 member for each work group for either the GLP-1 or the doula work group.
Glenn, this is Robert. I'd be willing to do the GLP work group.
Thank you,
If
Robert.
it's acceptable to everybody else.
It's great.
I'll help out whatever is needed.
Bill, that'd be great. It's the doula work group that we would need participation.
Yeah,
thank you, Bill.
Not an area I know, but I'll try.
It's an area that not many of us know. And if you remember, actually, I was reviewing, as I always do before the meeting, we ended up commenting on SEOW how we need to add some women to our board membership on SEOW. So that's, but yes, you will. I appreciate both of you two jumping forward, and our lame duck, Jeff, we will excuse you from doing anything because your hands are fully tied up with the innovation work group and centers of excellence. So we're all 4 of us are working it, and I sure it's what's made working with you all, and Greg, your participation, it's made it so interesting and good. So thank you all.
Well, and as Tom said, this would be summer school for all of us for these topics, and I think it's actually a really good education experience.
Yeah.
Because there's a lot.
We're not asking Robert and Bill and Greg, for that matter, we're not asking you to be experts. What we want you to do is actually to enter in the process with your excellent knowledge of what OEB is all about. It's the sometimes on these work groups you go down rabbit holes and you lose the overall view of what the impact is for entities, for members, and OEB as an institution. So and PEB as an entity. So we don't expect you to start to go to medical school or pharmacy school before you do this, you participate. Okay. Kirsten, anything else?
Nope, nothing else. Thanks, everyone.
Glenn, do you have anything else for us to, did we complete what we needed to do? I think we did.
Yeah, the only thing would be, Rose, do we have any public comment?
No public comment.
Okay. Thank you, Rose. Thank you all. We're giving back about a half an hour. So use that time to get out and have a walk. Bye-bye.
Bye.
Thank you.
Bye, take care.
Hey, Tom?